Hello, my name is Adam Kirking. I'm the Director of Operational Performance and Analytics with Imperium Health. Today we're going to kick off our 2019 ACO Quality Measure Spotlight Series by discussing the tobacco screening, depression screening, and depression remission measures. The tobacco screening measure is the same in 2019 as it was in 2018, but one of the unique caveats to this measure that makes it a little bit different than it was in 2017 is Medicare is really focusing for the preventative 10 measure on patients that were identified as a tobacco user and documenting tobacco cessation intervention on those identified tobacco users. This is something that makes the measure a little bit challenging for UPQC, where we have lower rates of tobacco users than other parts of the country. So those handful of patients within the ACO that are tobacco users, documenting that cessation becomes even more important. Now, Medicare identifies 616 patients for this measure to be audited, and in 2018 we only had about 50 patients that actually qualified for the measure because they were tobacco users. Something to keep in mind with this measure, it's asking about tobacco, not just smoking. So if someone dips or if they smoke cigars, that would qualify in addition to smoking cigarettes. And the measure is really focused on screening as well as documentation of those cessation plans. Now, with this measure, there are a couple patients that might initially show up on a list but wouldn't necessarily qualify. So if someone for medical reasons wasn't screened, most likely because of a limited life expectancy, as long as that was documented, that's okay. Or if there was medical reasons why, maybe even if we did this screening, we're not going to worry about the cessation intervention, that's okay as well, as long as it's documented. If you have a patient that was a smoker, they have cancer they're in the last couple months of their life, having that cessation intervention probably is not going to really add that much to the patient's life. Now, with this measure, it's important that we perform that screening at least once in either 2018 or in 2019. If Medicare does, or if you did perform more than one screening in that time period, Medicare will take the most recent one. And if the patient is a confirmed user, they must have some sort of a cessation plan in place. One of the things that makes this measure just a little bit unique is that you can satisfy it by phone. So if you identify it through a chart audit in November that a patient was a tobacco user, you can call them and perform some sort of a screening, or have an MA in the clinic perform some sort of a follow-up plan, and that's good enough. Now, one thing that we identified through the 2018 audit that was kind of a potential misstep was written self-help materials are not enough. So if you have a written smoking cessation document and you review it with the patient and then you document that you reviewed it, that's going to meet the measure, although simply handing the patient the brochure isn't necessarily going to satisfy the measure, and it may not positively impact the patient's decision to quit smoking quite as well as actually going through with the patient. Now, coding and documentation is something that we will always work to be just a little bit better at. And risk coding in particular is something that for 2018 we've really tried to emphasize within UPQC. Although this measure may not necessarily on its own drive improved risk scores. It is possible that nicotine or tobacco use can drive your risk score, but that's only in the case of toxicity, and that's actually associated with the major depression category. Although tobacco users do have higher rates of other risk-adjustable conditions, such as COPD, CHF, cancer, and diabetes. On the bottom half of the page, we have listed a few of the CPT-2 codes that we will recommend to make the quality audit just a little bit easier for yourself. I really consider these those breadcrumbs for when it gets time for the audit to make the audit just a little bit faster. The next screening measure we're going to look at is the depression screening measure. Now, there's actually two depression-related measures, and this is the one that's focused on the screening. So Preventative 12 is focused on patients that are 12 and older to make sure that we used a standardized depression screening tool on those patients. And if it was positive, meaning that we diagnosed the patient as having depression, from that tool, a follow-up plan must be documented on that day. A couple exceptions or exclusions for this measure are patients with an active diagnosis of depression or bipolar disorder. Maybe the patient refused. Maybe it doesn't medically make sense because it's an urgent medical situation. Or you have a patient in that functionally or kind of motivation wise, it didn't make sense to do that day. Now for those last three, the patient reasons, the medical reasons, or the kind of patient enthusiasm reasons or patient capacity reasons, it's important to make sure that you're documenting why you didn't do the screening. Because if you document why you didn't do the screening, that can help to have the patient almost be thrown out. So while it's not a 1 out of 1, it's at least not a 0 out of 1, because it's almost going to be thrown out, so it's like we don't count it. And as Medicare identifies those patients for the potential audit or for the audit, having the ones that we've documented that there's a reason why we didn't do the screening can help the overall ACO quality score. Now again, one of the things that makes this measure a little bit unique is that you do have to use a standardized screening tool. Now the most common one that we will see is the PHQ-2 or PHQ-9. So if you perform that PHQ-2 or PHQ-9, you're going to get kind of an initial score. And if you have a positive response on the PHQ-2, please always make sure that you're doing the full PHQ-9. But that diagnosis or that score needs to be interpreted by the provider, because we can't have the score alone be the kind of positive or negative. It really has to be the provider interpretation. It could be a gloomy day, it could be something else going on with the patient's life, but it may not be necessarily depression. And as a kind of final reminder, that follow-up plan must be documented on the same day. Now the 7 screenings listed here are not necessarily the only ones that you can do, but they're definitely the most common ones that we've seen. And making sure that you're using some standardized tool is definitely the best step. If you have any questions about your specific tool, please reach out to Lori or myself. With this measure, that follow-up plan is such a big deal because it's intervention as soon as we can. That intervention doesn't necessarily need to be face-to-face, but it does have to be the same day as the screening. One of the things that I will oftentimes talk about with the quality measures is something small documented is always better than something great that maybe didn't happen to meet the measure. Now, certainly we want to make a difference in every patient's life that we can, but to make sure that we're getting as much credit as we can from CMS, we have to have something documented. So it could be something as small as an additional evaluation, maybe a suicide risk assessment, referring on to another provider, pharmacological interventions, or it could be some other intervention or treatment plan, such as, separate yourself from what's causing the unnecessary stress in your life, what's causing you to be unhappy, or do something for yourself that makes you happy, such as going for a walk or not watching the Denver Broncos play football. To ensure that we're being as successful as we can with our risk coding, now it can be difficult to diagnose a patient with depression because of that stigma that's associated with it, but documenting that patient as having depression can be one of the best ways to best reflect the medical complexity of that patient. Here are a couple common examples of depression-related diagnoses, but those aren't necessarily the only ones that are available to you. And on the right, we have those CPT-2 codes, again, those kind of quality breadcrumbs to make our audit just a little bit easier for ourselves. Using those CPT-2 codes can make it so that when it gets time for the audit, it'll be able to go much faster. Now, I will always recommend doing the depression screen as part of the annual wellness visit, but using those codes can help to make it just a little bit easier to find that depression screen, whether or not it occurred. The final measure we're going to review today that kind of builds off that last one is the depression remission measure. So this is that second depression-related measure, and it's going to be similar but a little bit different to the last one. It's going to be, again, focusing on patients that are 12 and older, but for those patients that are 12 and older that have a diagnosis of major depression or dysthymia, we're looking to have a lower PHQ-9 score. So a challenge with a lower PHQ-9 score is you have to have the initial or that first one, which may mean we're going to have to reach out to other providers to get the best information possible. Because we're really trying to focus on the index or that initial PHQ-9 that's associated with the initial diagnosis of major depression and working to get it a little bit better. Similar to the last couple measures, there are a couple exceptions and exclusions, including patients that have had a previous diagnosis of bipolar disorder, personality disorder, schizophrenia, psychotic disorder, or any other pervasive developmental disorders. As well as patients that are permanent nursing home residents, it's always important for those patients that we are documenting and capturing that, because there is a few measures that they're excluded from. So we have that kind of initial diagnosis or initial PHQ-9, and we're working to see if we can get the follow-up, or the one that's done essentially 12 months later, it's 10 to 14 months later, that we can get that follow-up PHQ-9 less than 5, which can be really tough to do. But it's that constant effort of working with those patients that are maybe our most medically challenging from a depression perspective to hopefully be a little bit more successful. So again, making sure that if a patient is diagnosed with major depression, that we're accurately coding them. And a tip for coding is that codes need to be dropped codes need to be kind of reestablished every year in order to get credit from a risk perspective. You'd hate to have a patient that is still kind of struggling with depression, but we're not getting credit on how medically complex that patient is because we didn't document it correctly. And then because the goal here is to be less than 5, there's only one of those CPT2 codes that we're really promoting, and that's really trying to get that depression remission less than 5 within 12 months following. That was it for today's information. If you have any questions, please reach out to Lori or myself. Thank you so much for your time, and have a great day.